Guys, so today we are going to do a very important topic that AMC loves to test is that the COPD exacerbations. COPD exacerbation is one of the very important emergencies and very common emergencies that are seen in the air settings, and you have to be able to manage it very efficiently. So we have covered the topic of stable COPD management in the previous video. Now we are going to do COPD exacerbations. So how are we going to diagnose that the patient is having COPD exacerbation? Acute worsening of the symptoms of acute worsening of the symptoms of COPD. That is, the patient is having increased dyspnea and increased severity dyspnea. There would be increased frequency of cough. Sputum is increasing in volume. Respiratory rate is increased. That is tachypnea. The exercise tolerance is decreased in that patient. He is not able to do any routine work, or he is not able to walk a certain distance. So the exercise tolerance is decreasing in the COPD exacerbation. There can be some right heart failure signs like ankle edema and chest comfort. So these are the symptoms of acute exacerbation of COPD. These are the symptoms of stable COPD, but when these symptoms start to get worse acutely and sudden, we are going to diagnose it as COPD exacerbation. COPD exacerbation can be due to any comorbid infection or any other non-pulmonary causes that has precipitated the COPD exacerbation. So acute exacerbation of COPD can have similar presenting features as CVD, cardiovascular disease, because cardiovascular disease also has the symptoms of breathlessness, fatigue, and chest discomfort. So we have to be able to differentiate between these two by properly investigating and making the differential diagnosis and pointing out the differential features between these two. Now, the COPD exacerbation can be managed at home by the patient himself. Every patient of COPD is handed over the action plan, where there are the instructions to manage the acute COPD exacerbation. What are the indications for hospitalization? If the patient has an inadequate response to ambulatory management, the patient is having difficulty in walking between the rooms due to shortness of breath. He is not able to cover the small distance that is between the rooms. Unable to eat or sleep due to shortness of breath. Inability to manage at home. The patient has taken the short-acting bronchodilator, but it has not responded. So the patient is unable to manage at home. High-risk comorbids like the patient has pneumonia and other non-pulmonary causes are there, which can worsen the condition of COPD. So it requires hospitalization. COPD patients later on in the stage in acute exacerbation, when not treated initially, can develop the hypercapnia, and hypercapnia can lead to the patient towards altered level of consciousness. So it is a very important feature. The patient is having worsening hypoxemia or cor pulmonale. Patient is having worsening hypoxemia and cor pulmonale, worsening or new onset of central cyanosis that is pointing towards the hypoxemia, newly occurring arrhythmia, peripheral edema, development of peripheral edema, that is the patient is starting to develop the right heart failure signs. Hemodynamic instabilities, the acute respiratory failure, and any onset of new physical signs. So these are the indications for hospitalization. Now coming towards our management. So the management of COPD exacerbation is quite simple actually. It can be managed at home, and the first line treatment that is to be given is short-acting bronchodilators. Initially, the COPD exacerbations are treated with short-acting bronchodilators, inhaled short-acting bronchodilators that are salbutamol, terbutaline, and ipratropium. Keep in mind that the patients of COPD who are already on drug therapy, including drug therapy of LAMA, in those patients, ipratropium cannot be given. It is contraindicated for the acute management because it can cause the cardiovascular events. So, if these short-acting bronchodilators can be given by spacers PMDI, but if the nebulizer is the source, we have to use the compressed air rather than oxygen to avoid excessive and potential hyperoxygenation, which is harmful for COPD. We cannot do that in the COPD patients, and we have to use the compressed air rather than oxygen in the nebulizer, right? So after the short-acting bronchodilator, the symptoms are not improving. The patient can combine salbutamol and ipratropium. The combined effect would be able to control the symptoms. But still, the symptoms are not controlled, and the patient is not responding to the combined therapy of salbutamol and ipratropium. We are going to repeat the doses. If the symptoms remain uncontrolled, the doses can be repeated 3 hourly. But if the doses are required more than 3 hourly gap, then we have to seek the medical attention. One thing that we have to keep in mind that the repeated doses of salbutamol can cause hypokalemia and hypomagnesemia, and cardiovascular effects can also arise. So we have to monitor the patients if we are giving the repeated doses. Coming towards the steroids, so systemic steroids are indicated when the patients don't respond to inhaled bronchodilators sufficiently. So the 5 day course of systemic steroids is indicated. It shortens the duration, hospital duration, and the patients who can tolerate oral steroids, they are given prednisolone OD for 5 days, and who cannot tolerate, they are given hydrocortisone IV. Right, so the keep in mind that steroids are indicated when the short-acting bronchodilators do not respond sufficiently. So first-line treatment for acute exacerbation is always the short-acting bronchodilator. The patient do not respond to short-acting bronchodilator, then we are going towards the step up towards the systemic steroids, right? Then we have the antibiotics. Not every patient get the antibiotic treatment during the exacerbation. Only those patients who require intensive care and mechanical ventilation due to severe acute exacerbation, they have the chances of bacterial infection, so they are given the antibiotics. And another group of the patients who have increase in the sputum purulence and volume during the exacerbation, they are also suspected to have the bacterial infection. So these patients are also prescribed antibiotics, and the antibiotics course is given to them. Then we have the oxygen therapy. Oxygen therapy is given to the patient when he is hypoxemic. When the COPD patient is hypoxemic, that is the threshold for hypoxemia in COPD patients is less than 88%. But we have to give the oxygen therapy very cautiously in the patient of COPD because there is a risk of hypercapnic respiratory failure during the exacerbation, and excessive oxygen supplementation. Due to excessive oxygen supplementation, and it can cause mortality. So we have to maintain the oxygen between SpO2 at 88 to 92%, not more than that, because it can be harmful for the patient of COPD. Ventilatory support. First of all, the patient, which patients do need the ventilatory support? The patients who are undergoing the hypercapnic failure and acidosis, that is, the carbon dioxide is more than 745 and pH is less than 35, despite the optimal therapy. And they are undergoing hypercapnic failure. We are going to do the ventilatory support. Start the ventilatory support first with the non-invasive, and the patient is still not responding. We can intubate and put the patient on mechanical ventilation. But keep in mind that after the ventilatory support, there is an increase and the patient gets stable. If the patient gets stable and he is sent home, there is an increased risk of readmission and life-threatening events during the following year if he has a history of if he has undergone the ventilatory support for acute exacerbation of COPD. Now, what is the post-acute care following COPD exacerbation? We have to make sure every patient of COPD has a written COPD action plan. The patient has to be referred to pulmonary rehabilitation. If the patient if the patient has pneumonia and he's undergone the COPD exacerbation, the chest physiotherapy plays a very good role, and it is termed as pulmonary rehabilitation. So we have to send the patient to pulmonary rehabilitation after the COPD exacerbation. The patient should see the GP within 7 days of discharge, and admission following exacerbation should prompt consideration of advanced care planning. Once the patient of COPD has undergone exacerbation, and due to that the patient is hospitalized, this should prompt consideration for advanced care planning for the COPD patients. So I will summarize the COPD exacerbation management. First line is short-acting bronchodilators. If it do not respond, we are going to repeat the dose of short-acting bronchodilators. And if the patient do not sufficiently respond to the short-acting bronchodilators, then we are going to administer a 5-day course of inhaled corticosteroids, systemic steroids, and there are antibiotics, but not every patient get to have the antibiotics. Oxygen therapy if the patient is getting hypoxemic, and ventilatory support if the patient is undergoing the hypercapnic respiratory failure. That's it. Thank you.